welcome to our PDHPE Headstart lectures. Yeah, wishing everyone firstly a belated Happy New Year. I hope you all are having a wonderful New Year so far, and smashing out your goals, and have hopefully an awesome plan for this year. If you don't, that's all good. You don't have to have a plan for the year, but it's going to be an exciting year ahead, with the HSC, and of course all the good stuff that's yet to come in year 12. So welcome everyone to our PDHPE lecture. So firstly, once again, welcoming you guys from all of us here at 8 Notes. As you all know, 8 Notes is an organisation that's all about helping you and helping students succeed in general. And so it's lovely to have you all here today tuning into the lecture. And I can't wait to get into some PDHP fun. Now, before I get ahead, I do want to sort of talk quickly about the resources that we have to offer here today, and definitely have a look at these resources. I'm sure you'll find some relevant resources and advice and strategies that will help you this year, hopefully. So we've got study notes, hundreds of downloadable study resources that are posted up by your peers, and they help, and it's a great resource to sort of compare and contrast your notes, to consolidate your notes, and collate your notes as well. So it's an amazing resource. Then we of course have these lectures going on. So this week is our lecture week, so don't forget to go in and check out the other lectures that are relevant to you. We also have some text lectures going on, text analysis lectures, so certainly make the most of it. We also have online forums, videos, newsletters, ADA calculators, articles published by us, that includes study strategies and tips, and a bunch of other cool stuff. So definitely have a look at our website to find out more. Along with that, and I'll be talking about this a bit more today, we also have our very own tutoring website. So we've got TutorSmart. It's our online tutoring component from recent year 12 grads, and again, it's all about helping you. And I tutor English Advanced and PDHP here at TutorSmart. So I always like to say that TutorSmart is all about catering to your needs. So yeah, check that out if you're interested in it. We also have our study guides that are printed revision materials that are, again, written by recent grads. They're full of relevant info and top tips to help you get good marks. And an online version of that, which I like to call like a Netflix of all our study guides, is Ed Unlimited, where you have all the study guides in one place. And again, it's a wonderful resource in the sense that you've got all your guides for all your subjects. So it's in one place. You've got course materials like course notes, but you also have like practice question workbooks, and again, text guides. And as an English nerd, I think that's awesome. So once again, welcome. I'll be talking a bit more about these resources later on today, so keep an eye out for that. But let's get started with today. And before I introduce myself, I'd love to know you guys and how you all are doing today. So jump on to Slido for me, and we can start sort of talking to each other virtually, and I can find out how you're all doing today, where we're at with our with our PDHPE syllabus. And yeah, so remember, this is anonymous. This is about helping me gauge how you guys are all doing today. Cool. So we've got like a mixed feeling in the room. But I'm so glad to see so many awesomes, 50%. In my recent lectures, it's sort of been like the lowest one, and the highest one has been met another day closer to school starting out. There we go. It overtook. I spoke too soon. Okay. Alright, and I've got like the slider open on my side as well, on my laptop, my iPad, sorry. So if I keep looking that way, I'm just monitoring your questions coming in, and that way I can answer them. So please start popping your questions up. I'm happy to start answering them now, or we can wait until the very end to do that too. Either way works for me, but it depends on your questions too. Sometimes if it's very relevant to what I'm saying, I'll just answer it then. But cool, we are all alright. We're not, it's a good day, but it's another day starting, closer to starting school, so we're not feeling, too excited about that. Totally get it. Firstly, how was term one of year 12? So we'll start from 1, which is terrible, to 5, which is awesome. How did we go with year 12 term 1? Was it what you expected? Was it a bit too much? Alright, so I've got, like, everyone's at a 3. Okay, I've got a 4, yay. Another 4. Oh, look at that. That's good. A 5. Cool, okay, yep, and 1 and 2, that's fair. That's fair too, It certainly does feel like a significant shift from year 11. But once you sort of get into the gist of it, and once you sort of get through term 2, 3, 4 continuously, you sort of get into the flow of it, and it just feels so natural to be a year 12 student. I don't know, it probably doesn't make sense right now, but it will once you sort of get into it, because like term 1 it's kind of isolated. Like you've had year 11, then there's this one term of foreign stuff, and then you come back and you just like get into it, and then year 12 just feels so natural, and it's something that stays with you the whole year. So, and everyone's like, oh, you're in year 12, like that kind of thing. So it feels a lot more natural once you get to it. Yeah, that's awesome to see that we're at a 3.3. So we're all feeling all right with it, I guess. But hopefully after today, and once you get back into term 2, 3, and 4, you have a smashing term. So now I'd like to know what module you cover last term. So I've got someone who's done an elective, okay. Oh, 3 people have done electives. So definitely fill this one out for me, so that way I know where everyone is at. Okay. Wow, all of us have mostly done an elective. Okay. Still electives in the win. Alright, so I've got like 30% at core 1 and 20% at core 2, and then like 50% at core an elective. Okay, cool. Again, if you haven't filled this one out, please do, because just because it gives me a really good idea of where we are all at. And today we are focusing on health priorities in Australia, so it is, again, it's a head start in the sense that it's a refresher. So it's going to help you. It's going to help you sort of feel prepared for next term. Okay. So I've got someone who's done sports medicine. Awesome. All right. Yeah. So most of you have done an elective. Cool. And that's that's expected, because like I personally too, like my school too, did an elective after year 11, simply because, and more than likely, I'm assuming it's going to be sports medicine, because it ties up really well with like the prelim stuff. It may not be, but I'm just saying it's an assumption, because it ties quite well with the prelim stuff. Cool, so we've done an elective. So today, to those of you who've done the health priorities in Australia, it's going to be a refresher where we go through everything. And to my 67% audience who hasn't done health priorities in Australia, 70% of you will be going through health priorities in Australia today. So that's going to be helpful, since you'll get a head start on that. Cool. So now I'd like to know how we feel about core 1. So those of you who've done it, and I know it's not a lot, but how do you guys feel about it? What do we think? Is it easy? Is it hard? Is there like just too much going on and it's annoying? What do we think? Yep, I did. That probably is going to be the winning one right now, because most of you haven't done it yet. What about the others? Yep, it was alright. I do think a part of it, like once you get to it, like it's just sort of like a common knowledge of the health system. and of, like the health system around you and the world around you, really. Yep, so I've got all right and amazing. That's good. No terribles yet, so that's really good to see. So no one's feeling terrible with it. All right, cool. Nice. Okay. So we're all right with it. Cool. Now, what module are you covering next term? And I think perhaps the answer here might be core 1. But then again, it may be core 2 if you have already done core 1. So what are we doing next term? And if you don't know, that's okay. Just take a guess. Core 2, yep, okay. Most of us are doing core 2 next term. An elective, yep. Alright, wow. So most of us are doing health priorities in Australia next term, right now. Alright. So now this sort of helps me understand, like, we are going to focus on, again, a detailed sort of, like rundown of the module. So this really helps. So thank you so much for that. So, okay, most of us are doing health priorities in Australia next term. I've got some core 2 students and people who are doing an elective too. Perfect. All right. Awesome. So that's really good to see that 55% of you are going to learn it for the first time. For the rest of you, it's going to be revision, or if you are doing core 2 before core 1, again, you're going to get a head start on it. Awesome. Thank you so much for filling that out. And the second last one, what's the biggest concern with PD right now? How are we feeling in terms of like the workload of PD? What is it that you sort of feel like, yeah, that's a bit, that's something I need to work on? Do we have any concerns right off the bat? This is quite interesting because I do think that with PD, a lot of the time it's just like learning and remembering the content. Like with with English, it's always essay writing. Like that's a big one, essay and thesis. Okay, so I've got some using examples and study. Yeah, there we go. Yep, studying, remembering content. I think it's decent. Yeah, I do agree. I do think it's decent too, honestly. I feel like it's like once you get to having a good understanding of it and finding a way to remember the content in your own style, it does become pretty decent. Extended responses, yes, learning the content, remembering it. Essay, oh, there's an essay writing in there. I'm presuming that maybe extended response writing or like your big 9-10 markers. That's all good. Formulating longer responses, yes. Homework, trying to remember it all, absolutely. There's a lot to remember. Mentioning the key terms, yes. Remembering the syllabus, that's a huge one again. Like knowing the syllabus and knowing the points underneath the syllabus that the question will ask you to talk about. That's where your sort of your marks lie, and then being able to elaborate on that. How to study for PE, all the content, yes. Okay, mesmerizing syllabus, yeah. 12 markers, absolutely. Justification, yep. External response. So it's kind of like that, studying, remembering, and then applying kind of thing. Perfect. Thank you for that. And finally, last one for now. What are you hoping to get out of this lecture? What would you sort of like me to focus on? And that way, again, I can just, sort of go through the content in a way and focus on answering questions in a way that I know that we as an audience would like. Okay, revision is for health priorities, hopefully. But even if it's like general PE revision, because so many things in PE tie up together, that's all good as well. Yeah, revision study tips. So in terms of study tips, if you've got any, I'll obviously be talking about like the general, like tips for PDHPE. But if you are left hand side, yes, just the content, getting ahead on the content, how to best effectively revise the content. Yep. Now, if you've got specific questions in terms of study tips and like, things like how do I use class now as a revision, it may be best to pop that up as a question so I can answer that specifically. So if you've got, so like best way to study the content, pop those up as questions. That way I can come at the end and spend a lot of time answering them. Yep. learn about the first two course, recap and study tips and how to answer the question fully? Yeah, awesome. So if you've got specific study tip questions or study questions, please use Slido to ask those, simply because I'll obviously talk about it, but at the same time, I don't want to like forget it, you know what I mean? Like, cause more than likely I'll just go over it and I may not answer it in as much detail. So pop that up as a question, and that way I can spend a lot more time answering it. Also, upload each other's questions. That way I know what you guys sort of want the most answered. Okay, awesome. Let's do it then. Let's get into the content for today. I've got obviously practice questions for us to do later. So we'll get through the content first, then come back to Slido, have a go at some practice questions, and also okay, I've got those questions coming in. Thank you. Awesome. And also then go through, what do we call it? What did I say? Okay, so I was saying, I lost the track. Like I was saying, we'll go through the content, do some practice questions on Slido, and then I'll answer the questions. Okay, awesome. Let's do it. So firstly, just a quick little thing about me. My name is Aditi. I graduated in 2021 as Dax with an ADA of 95. I've got band sixes in English Extension, Advanced, PD, and Biology. I also did Chemistry and Maths 3 unit, but I always like to say we don't talk about that here. We just focus on the Englishes in PD and Bio. You'll know what I mean. You'll just know what I mean if you don't like maths either, but if you do, you'll still know what I mean. But anyways, I'm currently studying a Bachelor of Science and Bachelor of Advanced Studies Medical Science at the University of Sydney as a Del Yale Scholar, majoring in medical science and political economy. If you've got any questions specifically about like uni or my degree or whatever, please ask. I'm more than happy to answer that. Personally love reading good shows and sunny days. I'm currently overseas, so it's like 7:30 here when we started in the morning. So I just saw the sunrise, which is really nice. So it's turning out to be a sunny day, which I'm really grateful for. So let's get started for today. Like I said, we'll be going through Core 1 revision, or Core 1 Headstart for those of you who haven't done it yet. We'll then be looking at study skills and having a Q&A at the end, where I pass over the microphone to you for you to, ask questions and voice your concerns. So again, keep those questions coming, and then we'll go through it. Now, my job here is to break down that Core 1 syllabus and to make you feel confident and knowledgeable about what's to come. So I'll obviously be talking about the theory, on the right-hand side of the syllabus, but at the same time, I will be talking about, what your job is on the left-hand side, where you have to consolidate that learning and that theory to be able to apply it and answer the questions. We'll also be like going through the left-hand side. So if that was one of the questions that popped up, so don't worry about that. We'll be going through that as well. But if you've got any more specific questions about it, again, ask. Your job today is to obviously listen and that kind of, I've written taking notes there simply because it certainly can be hard to look at a screen for 2.5 hours and try and listen and focus the whole time. Like, that's a bit hard. So taking notes and trying to jot down things that stand out to you might be helpful in that. Please participate through Slido. Again, it's anonymous. Ask your questions. I totally always try asking questions, but knowing that it's anonymous can always help. And also ask lots and lots of questions. So let's start off. The first point that we've got is measuring health status, role of epidemiology, measures of epidemiology. So we're looking at how do we measure health status in Australia, and that's where epidemiology and epidemiological data comes in. And then what are the measures that we're looking at? Obviously, these are all of the measures. There are others, but we are specifically looking at mortality, infant mortality, morbidity, and life expectancy. So what are they? So firstly, epidemiology. It is the study of patterns and causes of health and disease in populations and the application of these studies to improve health. So it's about not only gathering data, but also applying that data in order to improve health, whether that's globally, whether we're looking at like global epidemiology or nationally. Now, why are we studying this? It's because collecting statistics about populations and their health in general allows us to identify the health issues that they're experiencing. Hence, in turn, to implement health promotion to improve Australia's health. So now we're looking at it from an Australian context. Now, the information that is gathered in epidemiology. We're looking at firstly life expectancy. That is the average number of years that a given gender is expected to live. So we do look at it like a comparison between genders. So we look at, so right now it's 84.5 years for females and 80.4 years for male. Remember, it's an average, right? Then we've got morbidity rate. That is the level of disease, injury, illness in a population. So we classify that under prevalence, which is the number of new cases, so the number of new cases that are coming through, versus prevalence, which is the number of cases, so prevalence, which is the number of cases altogether, and incidence, which is the number of new cases. So over there, you can sort of remember the in incidence and link that to the new. So like incidence equals number of new cases, or alternative, you can remember like prevalence is the number of cases altogether versus so incidence is going to be, the number of new cases. So think of this like with examples, like if you think of COVID, like prevalence globally, how many, or even Australia, how many people have already had COVID. So that's going to be the prevalence of people who've had COVID, versus incidence is the number of new cases this week. Right? Now, mortality rate is the number of deaths in a given time. So mortality rates for injuries is decreasing, for example, but for other, but that's an example to show you that mortality rate is the number of deaths in a given time. And finally, infant mortality rate is when we're looking at the number of deaths specifically in infants, children under the age of 1 year old, and that is per 1,000 births. So don't forget, it's not like a number on its own, it's measured per 1,000 births. So for instance, decreasing in Australia, but it's higher in Aboriginal and Torres Strait Islander peoples. Okay, now we've got that. We know what epidemiology is. We know what the what the measures of epidemiology and what is the role of epidemiology. But now on the left-hand side, we need to critique the use of epidemiology to describe health status by considering questions like, what can epidemiology tell us? Who uses these measures, and whether do they measure everything about our health status? So now your job is to use that information learned on the right hand side of the syllabus and apply it to analyze the health system in Australia. So now if you look specifically at that, firstly, let's look at what epidemiology tells us. Right? It's telling us the basic health status and like the major causes of diseases. It also highlights, inequities between groups when we compare results. If we look at life expectancy, we can look at the life expectancy of non-Aboriginal males and females, and compare that to Aboriginal males and females and see the difference and the inequity there. Then it allows us to identify areas of priority. So, for instance, we can see that the health status of Aboriginal and Torres Strait Islander peoples is, it's impacted a lot more. Like, we need to direct a lot more resources towards them. And so that's allowing us to identify that area of priority. Also allows us to evaluate effectiveness of treatments, whether or not treatments are working. And you can sort of link this back to that idea of prevention versus cure. We can see, obviously it won't be like immediate, like it won't be like an instantaneous, especially when we look at prevention, like you won't see an instantaneous decline. But over time you can see that prevention strategies work a lot better than prevention strategies work a lot better and a lot more effective than putting money into the cure for. In prevention is better than cure. Yes, so prevention strategies a lot more than actually putting money into the cure and into the treatment of it. So that's what I meant by that. So prevention is better than cure, and that's what epidemiological results allow us to visualize. Who uses these measures? Everyone. right? Everyone is using these measures. We are using them and studying them, but there are also like governments and non-government organizations, manufacturers of health products or services, and individuals who are using this to, where they come up with solutions, to pitch ideas about improving health, and a lot more other causes. Okay, so do these measures tell us everything about health status? Now that's the question, right? Now we know what it is, we know what it entails, who uses them, why they're being used, but the question is, do they tell us everything? In general, the answer is no, because there are limitations here, right? Firstly, obtaining data is difficult in like emergency situations. By the time valid and reliable data is collected and analyzed, the conclusion for a course of action may already be taken, so it's too late. Whether that's, think about like different policies, or think about different treatments even, where by the time we may get data, it's already too late. Other treatments or policies have already been implemented. Objective, it doesn't consider the quality of life. The health measures, they give us a statistic, but they don't actually tell the whole story. They don't actually tell us about the quality of lives, of the individuals, who are evident in those statistics. So it paints people as statistics rather than individuals who have different factors that are affecting the quality of life, right? So there isn't that holistic view of the determinants of health. So it's a numerical data. Observational, so it doesn't tell us why the trends are occurring. However, it gives us good insights. It's telling us that the trends are there, that these things are occurring. These are targeting specific populations, but it does not tell us why that is. Again, that links back to that determinants of health. Health workers in remote communities often lack the resources to conduct adequate data collection, and that lack of access may also present difficulties in communicating, that data in a timely manner. So in urban areas, metropolitan areas, it may be, a lot easier for health workers to actually gain this data, pitch their ideas, and then be able to get those resources in place. But in remote communities, that's a lot harder. Okay, so that's our first dot point done. Now let's look at the second one. Here we are looking at identifying priority health issues. So we will be looking at the social justice principles. We will be looking at priority population groups, the prevalence of the condition, potential for prevention and early intervention, and costs to the individual and community. We'll also be arguing the case for why the decisions are made about health priorities by considering questions such as, who do we identify? How do we identify priority issues for Australia's health? What is the role of the social justice principles, and why is it important to prioritize? So you would have come across social justice principles in year 11. So let's go through them. They've got firstly equity, right? So resources allocated fairly for equal opportunity. And I always like to sort of think about this image to draw out the distinction between equality and equity. Equality is when everyone's getting the same thing, but equity is when people who need the resources, or individuals who need the resources, are getting those resources. They're getting the resources according to what they need. So the shortest person needed the 2 boxes to see, while the second shortest person only needed 1, and the tall person didn't need any at all, right? So this highlights that some groups face more disadvantages than others, and in the case of inequity, more resources are allocated to those who need it more resources allocated to those who need it to create equity. For example, those of lower socioeconomic economic status, for instance, those with less money, lower education, and lower employment, they have less access to healthcare. So to counter that, we've got things like Medicare, bulk billing, and PBS in place. Okay, now let's have a look at diversity. So that is the acknowledgement that populations are made up of, like the population is made up of different groups, cultures, and languages that have and that results in different health needs. Like there's the diversity of health needs. So for instance, we've got Asian populations, but we also have immigrants with ESL needs, right? So an example here, that caters to all is firstly that Medicare is available to all citizens, regardless of the language they speak, right, or their age. Secondly, immunization pamphlets are available in different languages in order to reach out to more people. Okay, supportive environments. So that's about ensuring that all Australians are supported in their rights to access services and be healthy. So, for example, environments need to support our health. So, we need to have environments that promote healthy behavior. So, think about, we will obviously talk a lot more about this, and it keeps popping up throughout the syllabus, but think of like smoking free zones. You're not allowed to smoke inside office buildings, inside restaurants, inside theaters. So it is promoting a healthy environment where you're restricted to smoking, to in only certain places. Now, remember, social justice principles, they're the influences and the goals of identifying health priorities. So we need to be able to identify health priorities based on these three principles. If social justice is not attained within a health issue, if you look at tobacco smoking, if you look at smoking in general, and we look at supportive environments, diversity, and equity, right, or we look at other issues, we need to think of attaining social justice, making sure that the social justice principles are addressed within the health issue, and we want to prioritize that. Now, priority population groups. So some population groups suffer greater health inequities than others, and we've already, sort of touched upon it. Now we'll talk about it. And by focusing resources and prioritizing the groups that are suffering inequities, we improve those groups' health, right? And that obviously contributes to improving Australia's health in general. Now, let's look at prevalence. Firstly, prevalence again refers to how common the health issue is. The more common it is, the more we are going to focus on it and we'll want to prioritize it. The greater the prevalence, the more burden then it's going to have on the more burden of disease it's going to have on the Australian healthcare system. So remember, burden of disease is the thing that occurs as a result of disease. So we've got the disease, and then the burden of disease includes, obviously there's increased demand for health services. There are less resources available. There's obviously an emotional burden, and we'll talk a lot more about this when we look at the cost to individuals and communities. Now, looking at the potential for prevention and early intervention, right? So it's so much more efficient and cost effective to prevent and intervene with illnesses rather than to cure and treat those diseases. Now, remember, prevention is the act of stopping the disease from occurring altogether. So we've got, immunizations programs to prevent hepatitis B. We've got campaigns for sun safety. Think of slip, slop, slap. Think about, no hat, no play. All of these measures that are enforced from an early age to advocate for sun safety and prevent melanoma. Then also good diet and exercise to prevent obesity. Now, intervention is the act of interrupting a disease or stopping it from worsening. So, regular mammograms to detect breast cancer early and intervene with, before the disease processes. Then also, we've also got skin checks for melanoma. Now, costs, indirect and direct costs. So, remember, when we look at this, we're obviously thinking about the direct cost that comes to the individual and the community, like the financial cost to diagnose, to treat, and to care. But along with that, we also have indirect costs, that include that are related to the person, like the loss of income, them being absent from their job and having to find, and then the job's having to find a replacement, and the person perhaps losing their job in the process. And obviously, there are emotional consequences too. So, community, if you look at the direct cost to community, there's the treatment and caring cost. Treatment and caring, which costs billions of dollars. The indirect is that you'll have to find replacements in the work community, in workplaces. Then individual direct, obviously financial is the biggest one that comes to mind. There's financial cost. There's obviously, time cost in terms of like the time for appointment, time off work, and travel costs. And indirect costs, of course, are linked to the emotional trauma and the emotional trauma of both um, the people affected, their families, but also the mental health of the carers. Okay, so that's that point. So we've gone through all of that. Now I'm just quickly going to go back to, probably it's better to come out and then have a, okay. So I was just quickly going back now to just talk about this bit here, because we've gone through all of this. Now it's your job to argue about, how do we identify those priority health issues for Australia's health. So why do we prioritize? What are the priority population groups? The prevalence of the condition. Then what role do the principles of social justice play? So we talked about how the social justice principles are sort of the goals for each health issue. Like, we need to be able to address each one within the health issue. And finally, why is it important to prioritize? We look at again the prevalence of health condition. We look at the potential for prevention and early intervention, and of course the cost to individuals and communities. Now it's about consolidating all that we've learned here and being able to answer these questions. So you want to effectively if not today, like whenever you get the time, to sit down and say, okay, based on all of this, I can answer these questions and argue for each one. This could be this dot point here could be a big, let's say, 7-8 marker where we sort of have to talk about each one, or it could be a 4-5 marker where you talk about why is it important to prioritize. Depending on what the question is, we're now applying everything we've learned here to argue for each one. So as as a revision strategy, you can always go back to the syllabus, look at the left hand side and ask questions to yourself in terms of why is it important to prioritize, and then look at the right hand side and being able to answer each one. So that's answering the left-hand side, well, attacking the left-hand side of the syllabus. Cool, let's move forward now to looking at groups experiencing health inequities. So within the syllabus, it's specified that, okay, firstly, let's look at the groups experiencing health inequities that are listed in the syllabus. So we've obviously got ATSI peoples, we have socioeconomically disadvantaged people, people living in rural and remote areas, overseas born people, the elderly, and people with disabilities. Now, your job here is to research and analyze Aboriginal and Torres Strait Islander peoples and one other group that's experiencing health inequities. So we do that by investigating the nature and extent of the health inequities, the social, cultural, socioeconomic, and environmental determinants, and also the roles of individuals, communities, and governments in addressing the health inequities. So today we'll be looking at Aboriginal and Torres Strait Islander peoples, and then it's your job to either research one, if you haven't done it yet, or if you've already done it, to revise the other one, the other group that you've looked at. Okay, so let's look at nature and extent first. Alti people. So firstly, nature, they have lower life expectancy by an average of 10 years. They have higher mortality rates, they have higher levels of cancer. They're more likely to describe their health as poor. Alti peoples make up 3% of Australia's population, but 28% of the prison population. Overall, Aboriginal and Torres Strait peoples have an extensive health gap. Now, tips here. Look at the Australian Bureau of Statistics for more specific stats for multiple choice. So in multiple choice, you're likely to encounter like more specific stats in terms of, let's say questions like which cancer has the highest mortality rates, or what is the life expectancy gap between female non-ATSI peoples and female ATSI peoples. So questions like those where it's more specific. Now remember, nature, you are describing what the health, for instance, in this case, we're describing the health inequities that they're facing. And then in extent, we are going to, and then we're giving trends. We're talking about the trends that they have higher mortality rates, higher levels of cancer. That is the extent of the health inequity that they're experiencing. Tip here is that you don't want to get bogged down by the statistics, especially for short answer questions. So being specific really and knowing specific statistics is is going to be like the most important multiple choice. Again, there you don't have to know too many. Just having a general understanding and knowing your main statistics is going to be important for the multiple choice. But in your short answer questions, if you just describe the trend like higher, lower, increasing, decreasing, that's literally all you need for your short answer questions, and obviously long answer responses too. You can choose to go in a bit more detail, but that would be fine. Now, the determinants. We're specifically looking at social, cultural, socioeconomic, and environmental. So, social cultural, they have higher rates of domestic violence. Some adults associate with a clan, which can impart language barriers, and have suffered years of unjust oppression, which has led to distrust of healthcare services. Socioeconomic, they are within the lower income bracket. They have lower health literacy, which results in an increased participation in risky behaviors like smoking. They have lower rates of finishing high school, which contributes to lower health literacy, and lower employment rates, which equals to lower income, and also results in having like a lack, which also results in them being not able to afford as many services, health services, for instance, like gym memberships, or choosing or having the option to buy like organic foods and healthier foods. Finally, we've got environmental consequences. So environmental determinants, sorry. So we're looking at the fact that they're more than likely living in rural areas, which means there is a decreased access to services that only people available that is only available to people living in urban areas. Some are homeless, so sometimes health forms need an address for processing, and so without an address, they're able to receive those certain services. Okay, now let's have a look at the roles of individuals, communities, and governments. So, individuals, of course, are responsible for their own health. They are responsible for accessing information, for leading healthy lifestyles, and also participating in the health promotion that is initiated by the governments or NGOs, or health promotions that is available to them. Communities, elders, and leaders are involved in close the gap programs. So specifically, you can look at AIM, which is tutoring and education for Aboriginal and Torres Strait Islanders to address education inequities. Finally, governments are responsible for creating policy for providing funding to different programs that look at health promotion, and also for research. So let's have a look at the Remote Aboriginal Swimming Pools project. So this exemplifies an intersectoral approach. So this is now about individuals, communities, and governments working together. So this is a program in which it's like you are able to access swimming pools. The swimming pools based on your attendance. So firstly, the Western Australian government, provides funding for this initiative. Community, so pools are run and managed by the Royal Safe Saving Society, and the Royal Life Saving Society. And finally, individuals engage with the program, leading to positive health outcomes. And in one school, retention rates rose from 20 to 80%, and adolescent crime rates in some communities went to zero. So you can see here that when we have an intersectoral approach, we're able to achieve more, and I won't say close the health gap, because that's not, that is obviously going to happen at a bigger scale, but it's about health promotion. It's about, closing smaller gaps to get to that big gap. Okay, now that's done. What we did there for Aboriginal and Torres Strait Islander peoples, you need to do that for another group experiencing health inequity. So do the same thing, go through the nature, the extent, the determinants, and then the roles of individuals, communities, and governments. The role would stay same, like individuals actually using those resources, communities providing those resources, governments doing the funding and everything. That's sort of going to remain the same, but based on the group that we're talking about, you'll be giving specific examples. Okay, now looking at cardiovascular disease, the nature. So with this dot point, we are looking at high levels of preventable chronic disease, injury, and mental health problems. You are to research and analyze cardiovascular disease, cancer, and one other condition listed by investigating the nature of the problem, the extent of the problem. So here you have to give trends. See, it doesn't say statistics, it says trends. So you don't have to get too bogged down by the statistics. Risk factors and predictive factors, and the social, cultural, socioeconomic, and environmental determinants. And also we need to talk about the groups at risks. At risk. So now, same thing we're going to do for this job plan. We'll go through CVD and cancer, and then if you haven't already, you can go ahead and research one of these other conditions and do the same thing based on these dot points. So let's have a look. Again, if you've got any questions about any of this, I know content-wise it's a lot, but breaking it down dot point by dot point can help, to like simplify it rather than looking at it as like a one big whole, like a one big whole syllabus thing. Just break it down into those little dot points, and in terms of what you have to remember for each. Like for the first one, you need to know about epidemiology, what it is, what it measures, what it doesn't measure. With the second one, we're looking at the how we identify those health issues. We're looking at social justice principles, priority populations, prevalence of condition. Then we're looking at groups that actually experience the health inequities. And finally, now we're looking at the at the level of preventable diseases, and how those are like high levels of preventable chronic diseases that are preventable, but they have like high mortality rates. Okay, so now let's have a look at cardiovascular disease. So the nature of it. So cardiovascular disease encapsulates conditions and diseases of the heart and peripheral blood vessels. So it's not one disease, it's like an umbrella term for a couple of diseases which relate to the heart and the peripheral blood vessels. So firstly, the coronary heart disease. It's ischemic heart disease, a disease of the blood vessels that supply the heart, whereby blood supply and thus oxygen supply is cut off. So it includes angina, which is chronic temporary short episodes of chest pain, and heart attack, where blood vessels supplying blood to the heart, they suddenly get blocked. Peripheral vascular disease, that affects blood vessels in the limbs, EI to arteriosclerosis. So we've got arteriosclerosis and arteriosclerosis. Remember those. Heart failure, heart is unable to maintain a strong enough blood flow, and that can result in chronic tiredness, reducing capacity for physical activity, and shortness of breath. Here, we've got arteriosclerosis, which is the main cause of CVD, where there's a buildup of plaque on the inside of those vessels. It is a gradual process, and if it ruptures, forms a clot which can block blood supply and cause heart attack. So next we've got cerebrovascular disease, which is stroke. So disease of the arteries in the brain, which is caused by arteriosclerotic clots. So there's the interruption of blood supply to the brain, for example, and that equals to stroke. Also occurs as a result of the blood vessels bursting in the brain. So with each one, you kind of want to know what it is, how it happens. That's literally all you need to know, what it is, how it happens. You don't have to go into a lot of detail. Okay, now here it is. Let's have a look. So this is a cross section of a healthy artery. There's a T in the artery wall. So remember, tear in the artery wall. So with that, we're looking at, so there's, sorry, my goodness, the image. So there's a tear in the artery wall, then fatty material is deposited on the vessel wall. So we talk about the, the buildup of fatty material with heart failure as well, where there's that buildup of plaque on the inside of the vessels. So arteriosclerosis, and also, how that causes the disease of the arteries in the brain, which is caused by arteriosclerotic clots. And we also have narrowed arteries. They become blocked by blood clots. So all of this can, as you can see, can happen and can obviously lead to cardiovascular disease. Okay, Now, the extent of cardiovascular disease. Again, you want to know the trends, but for like your multiple choice questions, this can come in very handy knowing specific stats. So, 1 in 5 Australians suffer from CVD. It accounts for the second largest burden of disease. So remember, burden of disease is the cost of the disease that affects both, individuals and obviously governments. The rate of strokes has fallen by 25% in the last 10 years. So, if you use this in an example, you only need to say rate of of stroke has decreased. You don't have to, go into the full depth. This level again of detail is only needed in multiple choice. So, coronary heart disease specifically, the prevalence is increasing. The rates increase with age. It Males are twice as more likely to have it, and death rate decreasing due to improved medical technology. Now the determinants. Now obviously we have looked at what the problem is. We've looked at its nature. Now it's about looking at what is causing it, what within what's like the sort of the reason behind it. Now not looking at numbers, but we're looking at people and habits. So let's have a look at socioeconomic determinants. So higher levels of education, of course, leads awareness of detriments of risky behaviors, and thus, those people are less likely to develop CVD, a cardiovascular disease. Lower income equates to lower health outcomes. So, the social gradient, as the accessibility is lower and education is also generally lower. Now, remember, these are generalizations, but, but these generalizations are of course based on statistics, but they're still generalizations. And finally, inability to afford fresh fruits and vegetables. Again, if you've got less money, you'll focus on buying more food with less money. So sometimes buying fresh fruits and vegetables may not be an option versus buying a lot more groceries that, like more carbs, buying junk food that's going to last you longer. Social cultural groups, social cultural determinants. So growing up in a family who can smoke can obviously lead to you sort of having that habit as well, and that in turn can link back to CBD specifically because it's a risk factor. We'll look at risk factors in a second, but smoking is a risk factor for CBD. There's obviously peer pressure to smoke, and it's easy to eat poorly in a world of technology where junk food is kind of glorified and TV ads and everything. It is easy to eat poorly, and men more likely are to ignore symptoms. Environmental determinants, so the impact of those. Well, people living in rural areas have high mortality rates of CVD due to slower speed of accessing immediate medical attention. Finally, less access to overall services as well. Okay, now risk factors and groups of risk. So let's have a look at risk factors. They're sort of grouped according to modifiable risk factors, non-modifiable, and protective factors. So modifiable risk factors that you can change in your lifestyle in order to be less susceptible to cardiovascular diseases. So we look at smoking, diet with high salt and fat, being overweight, sedentary lifestyle, and hypertension, so high blood pressure. So all of these things can be changed, like quitting smoking, having a healthier diet, exercising regularly, and exercising regularly can sort of help all three here. Then non-modifiable risk factors, so looking at age, hereditary, and gender. Those are non-modifiable. We can't do much about that. And protective factors, so they're the opposite of modifiable risk factors. So they kind of go like complement each other very well. If you are in a question asked to talk about risk factors and protective factors, you talk about risk factors, and then you say on the other hand these are protective factors. So they're very complementary. So like having a healthy diet which is low in salt and fat, regularly exercising, not smoking or quitting smoking, and managing stress. Now, groups at risks. We've got specific groups at risk. So they include smokers, those who are overweight or obese, Aboriginal and Torres Strait Islanders, people with high blood pressure and high cholesterol, males, the elderly, and socioeconomically disadvantaged people. Now we're looking at a growing and an aging population. So we've looked at, the groups that are at risk. We've looked at the distinct diseases. Now we are going to look at a growing and aging population and how that is impacting the healthcare system. So remember, in that dot point, we've looked at cardiovascular disease, the nature and extent, the determinants, and the groups at risk. Now it's your job to do that for cancer and one other condition. Okay, let's have a look at growing and aging population. So let's firstly look at the concept of healthy aging. What is this? Well, look, Australia's population is growing and aging, as we know, due to decreased birth rates and increasing life expectancy and increased prevalence of chronic diseases. So elderly are more susceptible, and there's obviously then got that is then obviously going to lead to an increased demand for health services. So what we are saying is that the population is growing and it's an aging population. Elderly people are more likely to have chronic diseases, hence that's going to result in a greater need of health services. It is a process, so healthy aging is a process that includes behaviors and choices that positively affect risk and they reduce risk factors for chronic disease. So, for instance, economic growth. So, for economic growth, you want to stay in the workforce longer. Decrease that will lead to a decreased strain on the health services by the elderly. Um, then we are able to train young entrants to workforce and able to volunteer and take care of others. Okay, now let's have a look at this specific chart, and that tells us that compares the ages of males and females percentages in 2010. So it's telling us what the population looked like in 2010, and it's comparing us and it's comparing what that would look like to estimate it in 2050. So we've got in 2010, you can see the white hair. Oh, what did I do? Sorry. The white hair, we can see that it sort of forms like the white. It's a bit hard to explain this way with like my mouse because even I can barely see my mouse, but I hope you can just try to like keep an eye on my mouse, okay? So you can see that in 2010 we obviously have a lot of a growing middle-aged population, but it sort of remains constant here. But then as we progress to the predicted population for 2050, you can see that like there's a stark difference between the younger populations, like you don't have as many young kids, and it's starting to increase over here where we've got more middle age and definitely more elderly people. So like it's inversing. So like in 2010 we have more, so like think of like a pot shape, right? So it's again it's hard to I don't know if there's like a laser thingy here. I've used that in Google Slides, but I can't seem to find it here. But again, try to stick to my mouse here. So you can see that it's sort of like more bell shaped here, like it's going down. But then in 2050, you've got like less people here in the younger ages, and it sort of starts to grow like as you go up. So that tells us that in 2050 we're going to have we're going to have a greater aging population, and that is going to have effects on the healthcare system. Okay, I've got some good questions coming through. Keep them coming. All right, we're going to have a break soon, so stick with me here. Now, demands for health services and incremental effects. So we look at growing and aging population. So growing and aging population leads to increased population with chronic diseases, and that is of course going to have an increased demand on the healthcare system. Think of that not only in terms of treatment, but also in terms of like, needing assistance, needing like housing, needing also like hospital beds and stuff. So not just the treatment itself, but also like the added effects of that. There's, like I said, increased living in aged care. So increased demand for facilities and aged care facilities that will lead to an increased demand of aged care workers, of volunteers. So that requires more workforce training and recruitment in these areas. Overall, this leads to higher costs to the healthcare system, as well as risks demanding more services that Australia can currently provide for. So, availability of carers and volunteers. Now, a carer is a person providing informal assistance, so usually a family member or a friend. Sometimes it can be formal; they can be hired and paid. There are carers that are provided by the government, so carers NSW. There's of course family members and friends, and also carers in nursing homes. Volunteers are members of the community who offer their services to those who need it. This is unpaid. So think of Anglicare, think of Nursing on Wheels and Alzheimer's Australia. There is a greater demand for both these roles, and availability is not where it needs to be. You would notice that the volunteer workforce is constituted of elderly people, like middle-aged to elderly people. You don't have as many young people in it, which means that once those elderly people are not able to work anymore, there's going to be a reduction in the workforce, with obviously not as many people trained left and not many people left, which means that we need more younger people actually volunteering in the workforce to actually provide for our aging population, and that obviously is something to think about from a healthcare perspective too. Now, let's have a look at healthcare in Australia. So we're looking at range and types of health facilities and services, the responsibility for health facilities and services, equity of access to health facilities and services, healthcare expenditure versus expenditure on early intervention and prevention, impact of emerging new treatments and technologies on healthcare, and cost and access and health insurance. So here, what you have to do is once we go through this, you kind of have to think about evaluate the healthcare in Australia by investigating issues of access and adequacy in relation to social justice principles. So we are exploring questions of how equitable is the access and support for all sections of the community. How much responsibility should the community assume for individual health problems? Again, this is about consolidating everything that we've gone through here. You also need to describe the advantages and disadvantages of Medicare and private health insurance, example, costs, choices, and ancillary benefits. Okay, let's have a look. So range in types of facilities. So hospitals, we have both public and private hospitals in Australia. Medicare covers the cost of public hospitals. So if you have have to go to a hospital, and you've got Medicare, you're covered, right? Making them more, which makes hospitals more accessible to socioeconomically disadvantaged people, though private hospitals require either full payment by the patient or combined payment using a private health insurer. So we'll talk a bit about why there is that divide between public and private health hospitals, and what that means. But let's have a look at primary care. So GPs, nurses, dental. These are the frontline first point of access of healthcare where referrals are made. Medicare again covers the bulk of the cost, with many GPs choosing to add additional fees on the top of that provided by the government, though there are still some who bulk bill. So there is no extra cost to you. You can still pop into your your medical center, and if they bulk bill, you don't have to pay anything out of pocket. It's all done by Medicare. Next, we've got obviously public. So we've got like screenings and immunizations. We also have specialized services like mental, reproductive, skin, nursing homes. And we have pharmaceuticals benefit scheme. So we've talked about Medicare, and we would all be quite
like most of us will know Medicare really well, but there's also pharmaceutical benefit schemes, so which provides partial payments for many medications with set amounts being paid by the patient. So you are getting subsidies on medication. This is obviously quite important in terms of like the elderly people have access to it. You need to have certain like you need to have certain needs like those like pensioners, concession card holders, and war veterans. They are provided with the extra funding because of obviously various reasons, but the fact that they need them. So you are like given PBS if you show that there is a need for it, and if you sort of like tick certain categories in boxes. So it's again not for everyone, unlike Medicare, but it is quite important in sort of like from equity perspective because it is directed towards people who need it most, and it gives them partial payments. It gives them subsidies on their many medications. So like for instance, elderly people they have to take regular medication, and buying that regular medication is of course expensive, so they get those subsidies on it. Okay, now who is responsible? So obviously the federal government, they are funding through taxation national health programs such as Medicare and the pharmaceutical benefit schemes and research. So all of these programs are basically paid by us. If you're paying tax, you're paying for it, and all of these programs are funded through tax. Then we've got states, so the provision of health public systems, the development of health promotion activities like overseeing immunization, regulation, monitoring. And finally, we've got the local governments who are responsible for the implementation of health promotion activities like immunizations, for instance, immunizations in community centers or sporting competitions in community centers and community like fields. They're responsible for community hygienes like garbage and everything. That's garbage collection is the responsibility of your local government, and waste removal as well. So if you've got new couches, you put your old one out, the local government's responsible for clearing them off. Now, looking at health services for you, me, and everyone. This notion of equitable health services that are accessible by everyone. We are very lucky to have like a centrally funded Medicare in Australia, unlike other places, but here it's achieved by Medicare, by PBS, and health promotion initiatives, and that allows all Australians basic level of healthcare. It's diverse and it's for everyone. However, of course, there are barriers to equity. Firstly, there's cost, right? Like there are out of pocket costs that are not covered. For instance, if you use an ambulance to get to the hospital, your treatment in hospitals, if you've got a Medicare, will be covered, but ambulances aren't covered by Medicare, so you have to pay for that. There are long waiting periods due to decreased availability of health workers and increased demand of health services. So the waiting periods, if and it's been in the news quite a bit, especially in the aftermath of COVID, where the waits in hospitals have been quite long, especially for surgeries and stuff. Like knee surgeries and all of these surgeries that were not considered as important during COVID, so they were held off, and now there's a long waiting line, and people are waiting to have access to that. Then we've got language, religion, culture, and geographic location. They hinder equitable access, and they also hinder TV access to promotion initiatives. So promotion initiatives that are televised, that are promoted through TV. People, for instance, who don't like who may not speak English won't be able to understand it or take advantage of it. Similarly, with those who may not be able to access TV in a certain location won't be aware of it. So some specialists such as physio, chiro, dentists, they are not covered under public healthcare. So you would, if you've ever gone to the dentist, well for kids, there is like a certain cap that is paid by Medicare. So like you get like a certain fixed amount every year if you're under 18 that goes towards your dental for dental services, but after that you have to pay for it out of pocket. It's not covered by Medicare after you turn after you become an adult. So there is obviously inequity of access due to those costs. Also there's the difference between public and private hospitals, right? So private hospitals, they don't have any waiting time, right? So that is why private hospitals um a, a good choice versus public hospitals, especially when it comes to like surgeries, especially when it comes to like those like services, simply because there are no waiting room, there's no waiting time, you get the choice of room and the choice of doctor as well. With public health system, you don't get your choice of doctor or your choice of room, and there is a long waiting list as well. So to overcome this, Medicare, local after hours walk-in clinics, and there's also supporting mobile GPs. Okay, so now let's have a look at the money spent on healthcare and health promotion. So remember, prevention is cheaper than cure, right? And it's more effective than cure, because it targets risk factors and behaviors by promoting health rather than treating with expensive technologies, procedures, and medications. So prevention targets a wide range of people, whereas treatment focuses on the one person. Um, Again, it's about sort of thinking at this not only from a financial perspective but also from a more personal and not personal, I guess, from a more humanitarian perspective, that you want people, you want to prevent diseases rather than cure them. You don't want people to suffer, you don't want people to actually go through the whole process, right? So that's why we think of it both from a financial and humanitarian perspective. um, well, generally people think about it from a financial perspective, but you can think about it from a humanitarian perspective. Prevention targets obviously a wide range of people, whereas again treatment focuses on one person. Um, However, health promotion does not take immediate effect. That's the thing about it. Right? You don't sort of see instantaneous effect. Like if you've got like you've implemented no smoking zones, you won't see the smoking rates decline the next day. Like people just go, yep, I'm not allowed to smoke in here, I'm going to quit smoking forever. We don't see that. But over time, we see the impact that that has had. So, like I said, it does not take immediate effect. It does not take immediate effect. It has long-term impact. Hence, there is hesitation to relocate those funds. Because with treatment, you can treat it. You can sort of treat it immediately once you've got all the resources for it and it's done. But with prevention, because it takes time, think of it from a government perspective. Like, governments can say they've treated these many people, and they can say that, I've put this much money towards health promotion. But if by the end of their, by the end of their term, if they don't have any statistics to say, okay, actually this health promotion led to this much prevention, they are going to think that it's probably better to put money towards treatment and say, okay, we discovered this new technology, versus, we put this much money in educational programs to promote awareness for smoking, but you won't see immediate effects for it. So from that perspective, we do sometimes see that hesitancy for governments to relocate their funds from healthcare towards health promotion. Think of tobacco initiatives when you think of this. Think of the tax increases in policies versus lung transplant. Like, you guys have got initiatives in place. I'm going to increase tax and policies. But again, you won't see the number of smokers decline the next day. It's going to take time. Versus you can say, this is how many, lung transplants that were done. This is the technology we've got now. That, obviously is more tangible than the effects of the health promotion immediately. But over time, let's say 10 years, 15 years, you see the decline. You see the effect of health promotion. Again, if you've got any questions about this, please ask. I'm more than happy to answer any content related questions too, but I've seen some really good questions sort of come in terms of like responses and stuff, so we'll go through that very shortly. Now, new health technologies and their impact. So new health technologies, technological innovation has obviously made it possible for new health technologies to come through, and they improve early detection, they they also help in prevention and thus improve life expectancy and quality of life. So advances in treatments, it leads to advances in treatments and reduces recovery time, and they're also less invasive. Think of like laser surgery for eyesight or knee hole surgery. Um, However, they are expensive. They do increase the healthcare expenditure, and there are long-term and the long-term effects are unknown. So examples are MRI, vaccinations, keyhole surgery, lasers, and screenings. Now, the ultimate showdown. Let's have a look at the advantages and disadvantages of Medicare and private health insurance. So, advantages. So, broad range of so Medicare firstly offers broad range of high quality healthcare. You are able to choose the GP you want to go to. It is affordable, it is subsidized or bulk billed. It's also equitable because all people have access to it. All citizens have and residents have access to Medicare. The disadvantages, however, are that some important services are only partially covered or they're not covered at all. Again, think of like physio and chiro, like you need, for instance, physio, if you're physios, chiropractors, also your dentist, like it's not covered. There are waiting lists, huge waiting lists, and there are also limitations of choices due to availability of covered services. Private health insurance. Now, private health insurance is quite interesting because you get rebates by government. That's the first one. Like a lot of people have private health insurance, because rebates are given by the government, and there are also and that includes like tax benefits and stuff. Especially if you are making over a certain like tax line, like you get certain benefits from having private healthcare insurance. So that's why a lot of people would have it more than the services. It's about the rebates. But private health insurance, they give us access to ancillary benefits like physio, dentist, optical, not those that are not covered by Medicare. And with optical, we think of like making your glasses and stuff. That's not covered by Medicare. Getting an eye test, that is like I'm pretty sure that is covered by Medicare, but like getting new glasses, getting lenses and stuff, that is not covered under Medicare. But if you've got private health insurance with that cover, they will pay like part of it, like part of the money for your glasses, for example. Superior comfort in surgery and wards. You have the choice of your surgeon. That's quite important, and that's why a lot of people who need that treatment, who need those elective surgeries, they'll opt for it because they have the choice of their surgeon. But obviously with elective surgeries, they also have like no waiting list. That's a huge one too. Elective surgeries with smaller waiting lists in comparison to public hospitals. Again, we spoke about how COVID has delayed elective surgeries, and therefore people are waiting in the line a lot longer. There is, of course, the choice of public or private hospital care, and rebates are given by governments. Now, the disadvantages here are that it's costly. Premium needs to be paid regardless of the level of use, so you may never have to use it, but you're paying premium every month or whenever, like every fortnight, based on what your cover is. And there are still out of pocket expenses. Like you're still paying out of pocket expenses, but what we're doing is that a part of that is paid by the private health insurance. So, for instance, if you want your glasses made, you may still have to pay again, kind of speaking from experience here, you may still have to pay based on what your cover is. You may still have to pay a bit, but they cover quite a bit of it. I did see a question come up in terms of what is elective surgery. So elective surgery is like your surgeries, like knee surgeries and stuff, which are elective surgeries like transplants and stuff. That's elective surgery. And we saw like in COVID time how there was they were sort of postponed. Elective surgeries were closed because they were not considered as of priority at the time as COVID. So they are your elective surgeries that are not like life threatening in that sense, where during COVID they were postponed, but now after COVID we see that people need those specific surgeries and transplants and stuff. But because of that huge delay, there are longer waiting lines now. Hopefully that answers that question. Okay, now moving on to that second dot point, that second part of that second last dot point, where we're now looking at complementary and alternative healthcare approaches. So we're looking at the reasons for growth of complementary and alternative health products and services. We're looking at the range of products and services that are available, and also we're looking at how we can make informed consumer choices. So we want to be able to critically analyze complementary and alternative healthcare approaches by exploring questions like, how do you know who to believe? What do you need to make to help you make informed decisions? So if we look at this dot point, and like I said earlier, if you're thinking as a marker, you're making a practice question for yourself. You may make a practice question. You may sort of make questions. Um, like for instance, name a complementary and healthcare approach, and what is the reason for its growth, or how can consumers make informed choices when it comes to complementary and healthcare approaches. And I may make that like a 3-4 marker, and then I'll have like my first mark awarded for you to actually give me first mark awarded to like for you to actually give me the definition of complementary and healthcare approaches. Second mark for examples. Third mark for actually summing up how they can make informed choices, or 2 marks for that specific part where how they can make informed choices. So if you think like marker and you get into that practice of making the questions, getting and that will not only help you think like a marker, but it will make you um a lot more what's a lot more familiar with the syllabus as well. Okay, so complementary healthcare services, that is a health service which is sought by a person in addition to like the traditional or Western medical treatment. So it's complementary to that. It complements, your ongoing treatment. Alternative is when a health service is utilized instead of a traditional medical attention or treatment. So there we go. So, what are the reasons for the growth? Well, traditional medicines, firstly, are not may not be working for people, hence they're opting for like alternative services. There's growth of research into these products. They're being researched more. They're being developed more. So they are becoming more trustworthy and and there's more evidence for their effectiveness. Hence why people are starting to use them a bit more. There is also the development of regulatory bodies that have increased the credibility of these resources, like the Australian Natural Therapies Association. So they have been they're helping validate these treatments. Important to note that in Australia, you do not need to be actually registered in order to practice some of these alternative and complementary health services. However, if we are using these services, it's important to be aware, when we are addressing when addressing making informed consumer choices. Now, we also want to think about considering a more holistic and more natural approach to healthcare and treatment. And also, there is tertiary education qualifications that are available to practice these alternate and complementary health services. So that's why people are opting to use them more, because they're studying more. Okay, now here are a range of different natural, complementary and alternate health services. So let's have a look firstly at naturopathy. So naturopathy utilizes the natural medicine approach, and it seeks to use natural products to strengthen your immune system and speed up, the healing process. Naturopaths often treat patients by improving their diets or providing nutritional supplements using homeopathic treatments or herbal medicines. Um, aromatherapy, that utilizes essential oils from like plants in massage baths, inhalation, or like this topical application to produce different emotional and psychological reactions. They are, most are like calming, relaxing, therefore de-stressing, which assists in the recovery process. We also have acupuncture, which involves inserting fine needles into specific points on skin to applying various other techniques to the acupuncture points to restore balance and encourage the body to heal itself. And it is said to assist with like migraines and joint pain. Chiropractic, so they're treating the spine by using their hands to examine and treat different health conditions related to the bones and the muscles and joints. For some medical conditions, chiropractic services, they can be complementary or like a medical support, medical treatment by relieving the musculoskeletal aspects associated with the condition. So they are often quite popular complementary treatment based on what the condition is. Okay, now decisions. How do we make these decisions, right? So remember, firstly, research is a big one. You want to be able to ask someone how, who has used it, someone who's qualified, how they've used it. You want to research the person who is performing the procedure. You want to know what the side effects are, what the costs are. There is of course a lot of ambiguity, online as well, and there are unknowns when we consider complementary and especially alternative health services. So you want to be able to ask the person what questions like, what qualifications do you have? What is the treatment? What are the side effects? You know, if so, are they common? Will the treatment affect any other treatments that I may have or may choose to have? So if they aren't able to answer it, or if the answer is a bit dodgy, you should be able to, conclude that they're not a reliable resource. So research here again is quite uh yeah, it's like, well, especially with alternative health services mostly, like there is a lot of research to do on the internet. The internet's not always reliable. So when we're answering questions like these, if it's like an evaluate question, like evaluate how you can make informed consumer choices, for questions like this is where you'll go, okay, there's a lot of information on the internet, but at the same time it's unreliable. Or you can always ask the person, but at the same time, if they are, they may lie, they may not be reliable. So you want to be able to ask people who've already used it. So this is where you're sort of going pros and cons, and you're discussing the different parts of the question. After selecting, of course, it is important to reassess the effectiveness and determine if it's meeting your needs. So you don't have to continue through with it if it's not helping you out. And again, a useful resource, and in a question like this is worth mentioning, is the Australian Natural Therapist Association, that they are a reliable resource. You can check their website for registered practitioners as well, and you only want to perhaps rely on registered practitioners and not rely on non-registered practitioners. Okay, that's our last stop point, second last stop point over there. We've got one more to go, so let's smash it out. If you've got any questions about that, please ask. Let's smash that out, and then we are going to have a go at some of the practice questions that I've got for us from past HSC papers, and then we can answer a couple more questions and finish up. Cool. So now let's have a look at health promotion based on the 5 action areas of the Ottawa Charter. So by now you should be very familiar with the good old Ottawa Charter. We need to know the levels of responsibility for health promotion, the benefits of partnership in health promotion, for example, government sector, non-government agencies, and the local community, so that intersectoral approach, how health promotion based on the Ottawa Charter promotes social justice, and also the Ottawa Charter in action. So here you should be able to argue the benefits of health promotion based on individuals, communities, and governments working together, and the 5 action areas of the Ottawa Charter. So again, examples here are super important. Investigate the principles of social justice and the responsibilities of individuals, communities, and governments under the action areas of the Ottawa Charter. Critically analyze the importance of the 5 action areas of the Ottawa Charter through a study of 2 health promotion initiatives related to Australia's health priorities. So this is here you need solid 2 examples, because like you can get an 8-9 marker asking you how have the 5 action areas of the Ottawa Charter been implemented? Give examples to or name one initiative, or give examples for your initiative, something like that, where you actually have to talk about it. So let's firstly have a look at the 5 action areas. Now there's sort of 2 ways to remember it. There's DIPS CSAB. So developing personal skills, creating supportive environments, strengthening community action, reorienting health services, and building healthy public policy. Another one that I personally use that I like a bit better is dog crap smells really bad. Helps me remember it. It's a bit funny. Not very fond of dogs, so I always remember this one. So D stands for developing personal skills. C stands for creating supportive environments. S is for strengthening community action. R is for orienting health services, and B is for building healthy public policy. So dog crap smells really bad. If you're a dog learner, you'll remember this one quite easily as well. So, firstly, let's have a look at developing personal skills. So, it requires the provision of information, education, and life skill development. This increases options and control for individuals over their own health. So, this is all about education. It is essential to equip people for lifelong learning, right? So, this is where we are educating people through school, home, and community settings. Education development of knowledge and skills is aimed at modifying their behavior. So, for example, doing PDHPE from K to 10, kids kids learn to do the five. Kids alive. Yeah, live is not the word supposed to do there. But kids do like kids alive do the five. Oh yeah, kids alive do the five. So you teach your kid to swim. So these initiatives are, obviously catchy. They're all about students, sorry, children and adults and students, and teenagers and the population, general individuals learning, good, like learning and being educated and being aware. Creating supportive environments, there is a link between people's health and their environment, right? So this is where we require a socio-ecological approach to health. So we need to look at the maintenance of environments, right, and how environments affect people. So work and leisure should be promoted to health, not demoted. Like now we see, like for instance, big companies having like relaxation rooms and stuff, like game rooms and stuff, not relaxation rooms, game rooms and stuff and things, in order to promote work and leisure. Thus, health promotion should create safe working environments that are enjoyable, assess health impacts of developing infrastructures. For instance, like now companies have also started implementing, like you don't have to sit on a desk, you don't have to sit in an office. Like they've got like the standing desks, so you can sort of you're not sitting every day, you're not sitting the whole day. Like you don't have that sedentary work lifestyle. Obviously, there's also providing care. They're also providing care and support for people in various settings like work and school. So this is all about environments. Think of like school speed zones, no hat, no play, no smoking areas. That's all about reinforcing a healthy environment. Strengthening community action. It's all about communities working together, and community action is strengthened through communities being involved in setting priorities, making decisions, planning strategies, and implementing them to improve health from outcomes. So community would know what its people need. Like, if you live in a certain community, you would know what the health issues are. People, let's say you live in an area with a lot of elderly people, so things like people not exercising enough, like they're not able to go out enough. So those are like community priorities that you will bring up to the council, that you'll bring up at meetings, and those are then addressed. So the process's goal is to empower communities. For example, think of mothers and babies group, walking groups, self-help groups like Alcohol's Anonymous. So it's all about encouraging communities to increase participation in decision making, planning, and implementing of these services. Reorienting health services is about the shift towards a system that promotes health rather than curative services. So, health services need to support the needs of individuals and communities to promote health and prevent illness by considering social, physical, political, and economic environments. And this, of course, requires a greater health research and professional education and training. The shift, again, is on preventative care. It can, again, this one's a bit of a tricky one, but think of, this is all about prevention. We're focusing on the needs of the entire individual, not just, on the injury or illness or disease. So it's about prevention, it's not about cure. So there is that shift from curing what's wrong, and rather there's a focus on the holistic health before the illness even begins. So if you've got, for instance, like there's a smoker, who goes to their GP, the GP is focusing on asking them to use quitline health services and stuff. So that's reorienting the health service. They're not focusing, they're not curing what's wrong here. They're not starting to cure for lung cancer. They're not like, all right, let's start working on lung cancer because you're smoking every day. You're going to get out at some point. Obviously, that's a very generalized example. That just to give you an example, they're rather focusing on the holistic health that the person needs to quit smoking. They may have other issues going on which actually leads to that. So they may direct the person also towards like mental health support and things like that. So it's about refocusing the health services toward prevention. Another example is free screenings for skin and breast cancer, which encouraging the cessation of smoking or encouraging the cessation of smoking. Now, Building healthy public policy. This is all about, this is where policy development at all levels is seeking to promote health. Like it includes legislation, taxation, and organizational change. This is about laws and regulation, right? So they're made to foster equity and ensure safer and healthier goods and services. Think about, like, I think the biggest example here is sort of like RBD legislations, kids alive due to 5, fancier pool, and smoking bans and taxation on cigarettes. Like those are your big ones. Okay, now levels of responsibilities. How are communities, individuals, and governments working together? Let's have a look. So developing personal skills. So for each one, let's have a look at governments, communities, and individuals. So governments, they create policies and fund education to develop personal skills. Right? Think of your PDHPE education from K to 10. Communities, then those run those education training programs to help develop personal skills, like community health center education, um, or things like street smart and stuff. Then look at individuals. They participate and take own responsibility of education using the resources provided. Examples: signing up for locally run education sessions, attending school. Then we've got creating supportive environments. So governments, they plan, implement, and manage the infrastructure, like pathways for walking in parks. There's waste removers, sun shelters. There are also now exercise equipment in parks. Um, Communities, they help maintain healthy environments and they promote healthy behaviors. Now, community, for example, Clean Up Australia Days, fun runs, they maintain parks. Like you would see, like local exercise groups, as well in parks now with the equipment installed, and individuals need to use those resources implemented. For example, put your rubbish in the bin, keep the environment clean, and also support the health choices or join up those local exercise groups. Now, strengthening community action. So, governments can engage with community groups in the creation of policies. They can allow communities to provide feedback on policies before actually signing them, simply because, remember, the communities would know what their people need the best. So as a whole, if they're involved in the decision making, governments will obviously be spending their it would obviously mean that the money is spent effectively more than anything else. Communities have to they need to contribute to and take ownership of policies that are being empowered. For example, Aboriginal community controlled health services. Finally, individuals getting involved in and promoting community activities like promoting fun runs and engaging in community discussion and health issues. Okay, reorienting health services. So governments, now this is quite an interesting one for governments. Like they're providing funding, research, and creations of policies around prevention and health promotion. So they're looking at the determinants, not just the cure. Like we spoke about, why that's so important in prevention. So think of like TV advertisements, training of primary health sector to promote health as well as cure. Then we've got communities, so they conduct research and be involved in the promotion of the health. For example, Cancer Council conducts research around cancer, but also promotes better health choices in relation to the prevention of cancer. Then individuals participate in health promotion and taking responsibility of those preventative measures. For example, participating in jump rope for heart or getting advice from a GP on quitting smoking. Finally, building healthy public policy. Governments, they create and they're responsible for the creation and maintenance of policies. So close the gap, statement of intent. Another example is the National Tobacco Strategy, under which tobacco smoking is prohibited in certain areas, and the branding on cigarette packs, also includes warnings. Communities, they contribute towards developing and carrying out policies. For example, Aboriginal and Torres Strait Islander peoples involvement in close the gap. And finally, individuals acting in accordance with policies, like abiding by those no smoking zone rules as well. Okay. Now, holding imaginary hands of partnerships. Now, partnerships equates to sharing resources, right? So shared responsibility equals that there's more efficient, like there's more time efficient division of resources for health promotion initiatives, increased access to expertise and resources, community and NGO involvement mean that policy and health promotion will be targeting actual needs of the population, right? Governments provide research and funding, individuals are the stakeholders that invest the money, but they also partake in those initiatives, which underpins the success, evaluation, and future improvements. So this is all about that intersectoral approach where all parts of the communities are working together to improve health and influence its determinants in and sorry and influence its determinants. Determinants is often referred to as that intersectoral action of approach. Okay, now let's have a look at a case study. So we've got breast cancer mobile screening van. So as a result of this collaborative approach and this program, breast cancer mortality rates have decreased. Now, putting it all together. So the OC and the SJP. So the Ottawa Charter and the social justice principles. This is that last part of the left-hand side of the syllabus. So developing personal skills. Equity is also access to education for all Australians, right? So now it's about adhering to those social justice principles within the Ottawa Charter. So for developing personal skills, we want everyone to have access to those resources. Again, like PDHP is easily accessible as it's provided during school K-10 and there's no additional fee. Diversity education programs are modified to cater for the diversity within the population, like health classes, pamphlets, textbooks, and advertisements in different languages, utilizing images to cater for those with lower health literacy. Supportive environment, so people share their skills and knowledge within their environment, making it more supportive. Example, parents are educating their children and modeling for their children who do the same in their peer groups. For creating supportive environments, again, equity health promotion is built, health promotion that is built to achieve a supportive environment means that it considers everyone. For example, Alcoholics Anonymous is open to the public, allows a safe environment for all the people to be a part of it. Same thing with the no smoking zones, right? In bars and pubs, it creates an environment free of passive smoking for everyone. Diversity, in order for an environment to be supportive, it needs to account for the different people in that environment. So PCYC, Police Citizens Youth Club, so implementation to support the health of young people accounts for the diversity of a community in that young people also have health needs. So now we're focusing on health needs also according to age. And then finally, supportive environments. So creating environments that encourage healthy choices is vital in health promotion. So ensuring there are good parks for outdoor activities and like exercise equipment in all parks in all areas. Now, strengthening community action. So equity, all. That means that everyone is involved. Aboriginal and Torres Strait Islander people get involved in Close the Gap program, which allows them to strengthen their community while improving the health outcomes for their population. Diversity, it's about empowering like elders in Aboriginal communities and encouraging them to implement and to lead and address those health issues in their communities. And promote diversity of knowledge and acknowledgement of diversity of cultures within Australia. Then finally, we've got supportive environments. So health promotion that aims to strengthen community action by getting communities to address health problems by creating supportive environments in which the health problems can be addressed and also we can create solutions. For example, community volunteer groups maintain bushwalking tracks to create an environment which is supportive of exercise, but which is also safe at the same time. Reorienting health services, providing equity. It's for everyone. So providing free or subsidized screenings to all Australians via Medicare, which promotes equity. Diversity, ensuring promotion of screening and preventative initiatives in like multiple language through multiple channels. Finally, supportive environments, so immunizations in schools to prevent spread of disease in school and create that safe environment for all students. Finally, building healthy public policy. So, equity policy making in Australia is built to cater for all citizens, making it equitable. Like Medicare provides access to health services for socioeconomically disadvantaged people. Diversity public policy announcements for the diversity of our population, which seeks to provide, which is provided to all people groups. Also, policies to ensure resources are accessible in different languages. Like that's a main one here with diversity. Finally, supportive environments is that policymakers should aim to produce policies that promote supportive environments. It's about creating a healthy environment for individuals. So, I know that was a lot, but in essence, what we're saying is that the Ottawa Charter provides a framework upon which those health initiatives can be based on, right? And they will subsequently promote the social justice principle. And that's, your overall answer statement. That's what we're saying, that, the Ottawa Charter needs to be backed, needs to promote, so the health promotions, health initiatives need to be based on the Ottawa Charter framework, which will promote social justice principle, and then you want to give examples for each one. Intersectoral approach is one that involves all groups, including the government, including NGOs, communities, and individuals, working together, sharing their resources. OC in action. So there's the National Tobacco Strategy, which was implemented from 2012 to 2008. So DPS, it's about educating people. You can see the warnings on their cigarette labels. CSE, creating supportive environments. It's about supporting people to quit, right? So we've got posters doing that. And that, of course, will then also, link back to like social justice principles where there's the diversity, everyone is able to access these. The same thing here as well. Life skills, strengthening community action. So this is about promoting those life skills, about communities working together. Then we've got reorienting health services. So they have increased quitting by 50 to 70% by implementing, my quit plan, implementing apps that people are able to use. Finally, building healthy public policy, so using laws and taxes as a way to reinforce that the healthy behavior, and they've done that, and you can access the article there. But for instance, the most expensive country in the world to buy a cigarette is Australia. A pack of 20 cigarettes now costs £19 after the latest tax hike. So there has been, we've implemented higher tax rates for cigarettes and tobacco products in order to deter people from buying them. So now, studying. Example, syllabus, and practice. I've talked a lot about it. Remember, understand the word. Make sure your response is easy to read and it's relevant. You don't have to use super sophisticated language. Multiple choices process of elimination, so you find the most correct answer. Now we are done. I will come back to this. But that's it for now, content-wise. Now let's do some practice questions before we run out of time. So here I've got the first one today for us. What type of cancer currently has the highest mortality rate in Australia? So definitely answer these out. It's anonymous. Even if you get it wrong, you learn by then seeing the right answer and remembering that you got that one wrong. So have a go with this. What do we think? Oh, no one's answering yet. Okay, one person. Awesome. You're the first brave one. Well done. Everyone else? Okay, there we go. It could be that I'm lagging. I don't know. I hope I'm not lagging. Okay, what do we think again, guys? You learn the most by getting it wrong, really. So even if you get it wrong, I'm not gonna sit here and think, you don't know what you're doing. Please don't feel that way. It's if you haven't, especially if you haven't done it yet. Take a good guess if you don't know. If you have done it, you've forgotten, take a good guess. Got 10 minutes to go, so I'm going to fly through these. I'm going to wait for a couple more people. If not, then we'll move on. What do we think? Again, have a go. If you get it wrong, it's all good. So the answer here is lung. Now this one is lung cancer, even though I can totally get why a lot of people did skin cancer. The right answer is lung cancer, because it has the highest mortality rate. Skin cancer is close by, but lung is the correct answer. This was from the 2020 or the 2021 HSC paper. Okay, moving on. Which of for which of the following has there been an increasing mortality rate for both men and women over the past 10 years in Australia? Again, take a guess here. Yep, I've got one answer, which is awesome. What do we reckon? Again, even if you get it wrong, not the end of the world. Am I gonna get more answers? Yep, cool. Nice, okay. Getting a diversity of answers. Coronary heart disease, alright. Dementia's lead, dementia and Alzheimer's. Coronary heart disease, cerebrovascular disease, lung cancer. What do we think? Okay, alright. 5. Get your answers in, guys. Come on. 4, 3, 2. No one's answering now. Okay, one person. Awesome. The answer is D, dementia and Alzheimer's. Over the past 10 years, it has increased for both men and women, and now it's like the top one of, like, pretty sure in women it's like the second or third, and in men it's like the fourth or fifth leading cause for mortality. Cool. Moving on, what could be an advantage for an individual who has private health insurance? Hopefully, we're able to answer this one because it's like content related. That one was a bit on, guessing the statistics a bit. What do we think? Alright, I've got one answer. Everyone answering now. Come on, put your answers in. Again, if you get it wrong, you learn the most by getting it wrong. But take a guess. Yes. Like it takes us a bit of a while, but that's all good. Please answer it. Again, it's anonymous. I'm not able to see who you are. I'm not going to sit here and think, oh, you got that answer wrong, because it's all good. Tells me that, we've listened, we are working on it, we're learning the content, and that's all I need to know. Okay, cool. One more, come on, guys. It's like every time, like, less people are answering. Yes, thank you. It's that 11th person. Okay, the correct answer is that the cost of some ancillary health services reduced. I can definitely see where we would have gotten confused here. So the recovery time after elective surgery in a private hospital is decreased. Well, the recovery time is, you may think that, but the recovery time will be based on the surgery. It will be based on the condition. So even the waiting list is definitely reduced, but not the recovery time. So this is probably where we got a bit, like, we saw this bit and thought, yep, that's it. And I totally can see where that happened. But just make sure you read the question properly. I just, yeah, that little trick question there. The Medicare levy needs to be paid. The Medicare levy, we're paying it in tax. Everyone needs to pay it. But with private health insurance, you get rebates on it, which means like you're getting like benefits on it in your tax, basically, so you can get some money back on it. So there's the rebates from the government. Okay, which strategy is most likely to reduce the current impact of a growing and aging population? This is the last one. Please fill this one out. What do we think? Okay, still waiting on everyone. Okay, awesome. So, which strategy is most likely to reduce the current impact of a growing aging population on Australia's health system and services? Come on, guys, put those answers in. Just have a go, even if you get it wrong. Who cares? You've had a go. That's what matters the most. So, increasing support services that enable older Australians to keep living in their own home, providing education programs in secondary schools to reduce the risk factors for preventable chronic disease, introducing an application fee for individuals to register as volunteers, sending annual reminders to older Australians, encouraging them to register for government support programs. Now, okay, cool. I'm going to reveal the answer, and it is the first one. Again, I can see why we would have gone for B and C. With B, providing education programs in secondary schools to reduce the risk factors for preventable chronic diseases, it makes sense. But remember, we've talked about like we want to reduce the current impact. So that's about the future impact. We're focusing on the current impact. That's where there was that trick. That's where it lied. So again, just a matter of reading the question. Introducing an application fee for individuals to register as volunteers. So the application fee would mean less people are will want to register because they have to pay money for it. It could have like he probably took it as a sense that we're paying people to register, but it's just the other way around. But well done on answering it. And now finally, I'm going to open up my last poll for today. Please leave some feedback for me as to how helpful you found today's lecture. And if you